We will go ahead and get started. So if you're trickling in on Facebook, we're just getting underway for equine gastric ulcer syndrome with Dr. Amy Polkes. I'm Kristen Kovach-Bentley from the Retired Racehorse Project. I'm the communications manager. We've started offering more of our educational webinars to the general public on our public Facebook page because education is an important part of what we do. So this webinar is being offered for free to all of our followers, all horse owners, regardless if you have a thoroughbred or not. Certainly really good information for all of us with thoroughbreds and anyone preparing a horse either for the makeover or just in general for a second career. So we're really excited tonight to have Dr. Amy Polkes. She came highly recommended. And when I spoke with her initially to talk about this webinar, I learned a lot just in that 10-minute phone conversation. So we're really excited to have her along tonight. Dr. Amy Polkes is a board-certified equine internal medicine specialist. Dr. Polkes received her Bachelor in Science from Cornell University and her degree in veterinary medicine from Purdue University School of Veterinary Medicine. She was in private equine practice for several years before continuing her training at the University of Florida College of Veterinary Medicine with a residency in large animal internal medicine. In 2002, after completing her residency program, she established an equine internal medicine mobile consulting practice in Maryland and Virginia, as well as providing consultation for Antech Diagnostics on equine medical cases. Dr. Polkes has now grown her referral practice, which is Equine Internal Medicine and Advanced Diagnostic Services, or EQUINE IMED for short, to provide mobile equine internal medicine services in Maryland, Virginia, Pennsylvania, New York, and Connecticut. Her goal is to provide an alternative to referral institutions, allowing for evaluation at your farm or at your primary veterinarian's facility. So a couple of just quick housekeeping. I'm going to turn it over to Dr. Polkes here in a moment. If you guys have questions, please write them in the comments on Facebook or into the Q&A or the chat here on Zoom. And we will round up all those questions and we'll get to them at the end. So I'm going to turn Dr. Amy loose with her presentation now. Thanks, everybody.
Thank you very much for that introduction, and thank you for having me here. So today, as you said, I'm going to be talking about equine gastric ulcer syndrome. So I'm going to start off with the definition, anatomy, causes, diagnosis, treatment, and prevention. We'll just go through each one of these one by one, just so I can make sure everybody understands, what we're talking about when we're talking about equine gastric ulcer syndrome. So starting with the definition, this describes a condition of disease in the distal esophagus, the non-glandular or the squamous mucosa, the glandular stomach, and the proximal duodenum. But we are not going to be talking about, hindgut ulcers. So some people ask that question when we talk about the sort of bottom of the stomach, but that is not the same thing. So what about the anatomy? The horse's stomach is, as you can see here, it's the smallest unit of the digestive tract, with about 2 to 4 gallons of capacity. And it has the smallest stomach in relation to body size of all domestic animals. So that's just kind of an interesting, fun fact there. Hold on, it doesn't want to advance here. So I'm going to just go through each of the pictures here to show you what we are looking at when we are scoping a horse and what this looks like. So we're coming through the esophagus. So this is what the anatomy looks like in real time. And horses have a really unique stomach where the top portion, again, is what's called the squamous mucosa. And right in the middle is a division called the margo plicatus. And this divides the stomach into 2 portions. And the bottom portion is the glandular mucosa. And as you could see here, this is really what it looks like. And it's very unique. And when we're talking about ulcer disease, we do separate them into talking about squamous disease and glandular disease because they are 2 different linings of the stomach, and the disease in these 2 areas is very different in how it behaves and how we treat them. So then again, moving on to what the anatomy looks like, if my scope is coming in here, as you could see off over here, so the scope is coming into the stomach and it's sort of wrapping around this little small area here that we call the lesser curvature of the stomach, and it is looking down towards the exit of the stomach called the pylorus. And so here is a depiction in real time again, where the scope is coming into the stomach, it's sort of wrapping around and looking at the backside of the stomach and the exit of the stomach. And then when we are looking at the exit of the stomach called the pylorus, this is what it looks like, and this is going into the small intestine right here. There's the opening into the small intestine. And then we can actually pop the scope right through that hole. And here we are looking at the small intestine. And that could be important as I move on in more of my discussion here. If we do have a horse with, let's say, weight loss, or we see something in this area of the stomach, we can put a biopsy through the scope and take a piece of the small intestine or anything that we see down there. So this does actually allow us to be able to get biopsy samples, et cetera, in the area of the small intestine. So now that we understand the anatomy of the stomach and what ulcers are, we're just going to talk a little bit about what are the causes. Why do horses get ulcers? That's sort of the million-dollar question, right? We can have many causes: changes or exposure to acidic gastric contents, stress, and we're going to go through each one of these individually. Helicobacter, which is a bacteria, non-steroidals, butanamine equiox, mechanical, management, cribbing. These are all things that could potentially cause ulcer disease. So let's talk about acid secretion first. So horses are, again, they are unique and they don't have a gallbladder. Here is a picture. This is taken from my scope, actually, where I've come into the duodenum. And here is what's called the duodenal papilla. Here's the bile duct. And I don't know if you could see this squirting right out here. So I'm in the stomach. The horse has been fasted. He's not eating and still continuing to just pour acid out. And that's why the bottom of the stomach looks like this. So when they're not eating, they're still just secreting acid. Whereas you and I, when you eat, your gallbladder spits out acid, and that allows you to digest your food. So this causes a problem. And then the acidic concentration in the bottom of the stomach leads to issues, which we're going to talk about right here. So the pH is actually interesting in the stomach. It can go from very, very low pH, so very acidic of 1 to 2, to as you get higher and higher in the stomach, when you have like a mat of feed or hay, etc., you will get a higher density pH going up to 6 or 7. Or when we are treating with drugs for ulcers, that's the idea, is to raise the pH. So we really recommend measuring the pH. So whenever I'm scoping a horse, I'm always measuring the pH to understand what the pH of that stomach fluid is, or we can even measure that pH after treatment to see how well our treatment is working. So again, this is, part of the issue is that they constantly have this very acidic fluid in the bottom of the stomach. So what about stress? Stress is, could be anything for any horse, right? They're all very different. But we do understand that there are very specific things that can cause stress in horses, and it's probably compounding factors. And again, different variation in horses. So one really important thing that we all understand is that horses are herd animals and they are social creatures. And generally speaking, horse-to-horse contact is a really good idea. This is sort of how they are naturally, and I do understand that sometimes that's not possible, whether it is for the safety of the horse or other horses, or it's just the environment that they're in. But we really try to socialize them because it is very stressful for them not to have socialization. And if they can't be directly with another horse, that nose-to-nose contact across a fence is actually important. So even if they can't be in the same paddock together, having them be able to touch is very important. Or getting them, a donkey, a goat, or something that could be a companion. Of course, pecking order in the pasture, if they're turned out, pecking order it could be very stressful. And sometimes we don't always understand the herd dynamics and, what's happening, or, there's an alpha horse, or, all those things. And sometimes when we have a horse that we don't really understand why they have ulcers, we have to look at things like that. Like, are they getting beaten up in the pasture? Did they just lose a pasture mate? Did, someone move away? Did they just move to a new place? All those things can have a very profound effect on them. So it's important for us to understand all the socialization parts. for a long time, the question was, does cribbing cause ulcers, or do ulcers cause cribbing, et cetera? And there were some studies that were done that did show that horses that crib did have a higher incidence of ulceration. It also seems that horses, when they have ulcers, the cribbing behavior can produce more saliva. So it can become a bit of a catch-22 situation where they have ulcers and then they're cribbing, and then they're cribbing and it's soothing the ulcers. And then, again, it can go back and forth. And then, here's the question about showing, transportation in, can that in and of itself cause ulcers? Again, very individual, but there have been some studies that have shown that just the actual act of transporting a horse can cause very, very low grade ulcers in some horses. That's why sometimes it's recommended you're going to treat them or prevent. We'll talk about it later before you're transporting. But also it could be the friends that are left back at the farm. So it again, it's very individual, but these are all things that we think about, and obviously other variable. Well, what about Helicobacter? I'm not going to really talk about this much because this is a bacteria that is associated with ulcers in people. We have never seen this in horses. It has definitely been looked at. We don't really understand whether this is a role, whether Helicobacter plays a role, but it does not seem to be a problem in horses. However, other bacteria and changes in the bacterial flora in the stomach that could potentially potentiate ulcers. But again, the specific bacteria Helicobacter that occurs in people, we have not associated that directly with horses. I'm sure everybody has heard about the fear of giving your horse bute or Banamine or Equiox, as far as it's going to cause ulcers in my horse. The reason for the concern here is, if you look over here at my picture, this is the pylorus. So this is going down to the exit of the stomach, and you see all this ooey gooey stuff. This is the really good stuff. This is the stuff that really protects the mucosa of the stomach. And non-steroidals, such as bute, Banamine, or Equiox, they can have an effect on that sort of ooey gooey lining, and it can block that. And so that's where, there is a concern that if you block that you could potentially have an effect on the mucosa and cause ulcers. Equiox is sort of the newest version, and this is supposed to be the least innocuous as far as not causing ulcers. But there is some recent data that shows that it may not cause ulcers as often as we think it does. And I've certainly scoped many horses that have been on non-steroidals, even for sometimes prolonged periods of time, whether it's an older horse that needs a small dose of Equiox for comfort for arthritis, or a horse that's been injured or has an eye injury or something, and they don't always have ulcer disease. So I do think that it can play a role, but we probably don't see it as much as people might think. So I wouldn't be afraid to give non-steroidals unless you have a known problem with your horse. Mechanical, this to me is one of the most important slides, because I think that this is where we really run into problems more than anything. Al Merritt, who is actually at the University of Florida, has done some wonderful work on equine gastroenterology, but he really showed that part of the problem of why horses get ulcers, and the way he showed this was looking at horses and scoping them while they were on a treadmill, was showing that high density liquid, again, that really acidic contents of the stomach that was at the very bottom, would splash up and actually damage the mucosa up at the top, that squamous mucosa that we showed. And so the mechanical effects of ulceration are really important. And where this comes into play is when we're talking about prevention, which again, we'll talk about a bit later, is how do we protect that stomach against this mechanical effect to keep the pH of the fluid such that it isn't really low and acidic and able to damage the mucosa. So this was a really interesting finding where, it really showed that it's not just whether that fluid is acidic or how you're feeding and all of this. It also had to do with the mechanics of what's happening with that fluid. Feeding practices, I think everybody has sort of heard, and understands. There's mostly low carbohydrate feeds out there, that really high carb feeds, things that have a lot of molasses, sort of the old sticky sweet feed, really promotes volatile fatty acids. That's the VFAs. And sometimes you can, if you have too many VFAs, you can have a lower pH, and it can increase the potential for ulcers. VFAs are good; they are good for digestion, and they're important in the in the hind gut and other areas. But we do have to be careful about feeding feeds that are way too high in carbohydrates. And I think, again, things that have really changed on the horizon has been that's sort of common practice now, and a lot of people are very aware of not feeding things that are very, very high in sugar, again, all those sort of sticky sweet feeds that we used to feed, and we have a lot more options for low carbohydrate feeds. And then again, feeding practices, management, just making sure that horses are, having good quality hay, et cetera. Where again that we can run into problems and causes of ulcers is that when we are not feeding them the way that they are meant to eat, right? Horses out in the wild, they continuously graze, and they not only do they graze, because I have people that are say, well, I have hay in front of my horse all the time, but they only go out an hour a day, let's say. And we know that, again, in the natural environment, and horses in the wild, they can walk miles while they're grazing. And it's very important for gastrointestinal health and motility, et cetera. It's just like if you sat at a desk all day and ate versus if you were walking and moving, et cetera, it changes your digestion dramatically. And so it's not just about that they have to have hay at all times. It's really important how you feed them the hay. And so management can play, a really big role in preventing ulcers and causing ulcers. If we're not feeding them properly, if they have they don't have enough hay in front of them, if that stomach stays empty way too long with all those acidic contents in there, so we have all these kinds of options that we can, again, when we talk about prevention, we could talk about all the things that we can do in our management to help. So what about clinical signs? And I think this is, so incredibly variable. I get called out to do gastroscopy for anything from a horse that has chronic colic, acute colic, they are girthy, behavioral, change in how they're eating, weight loss. There's just so many things that can have a clinical sign. So it's really impossible to know whether they have ulcers or not, because the clinical signs are so variable, and again can really range anywhere from just a behavioral concern to an acute significant colic. And then back to the prevalence, what horses are going to get this? I mean, really, again, we're talking about the thoroughbreds. When some of the first studies came out, when we finally had a scope that we could actually get into the horse stomach, right? Because we had to have a specially made scope that's 3 meters long. It just didn't exist. And so we weren't really able to look in a horse's stomach. Once we started looking and seeing, the prevalence was incredibly high. And you've probably heard, 90% of racehorses have ulcers, or other performance horses, et cetera. But honestly, I think that things have changed a bit, because we didn't understand so much what was driving ulcers. And now that we understand a lot more about nutrition and management, and we can see the ulcers, and we understand how to prevent and how to treat them and all of those things, I really think that prevalence has dropped dramatically. And again, in my own practice, I scope a lot of horses, but I also scope a lot of horses that do not have ulcers. Every horse I scope does not have ulcers by any means. And also there's a lot of variation, which we'll be looking at, but it really can be anything, honestly, from that retired horse out in the pasture. I've had some horses that have surprised me the most, where you would take, a young thoroughbred off the track and they have a beautiful stomach. And then you take an old retired horse that maybe they lost their best buddy, or they've moved to a different farm, or they really liked working and they're not working anymore. And that horse is the one that has ulcers. So I think we can't always predict. But I do feel like the prevalence, although it is very important, isn't quite as high as we used to think it was. So how do we diagnose? Gastroscopy, we need to look, and so this is the most important thing. How is the procedure done? I withhold feed for about 16 hours. People are anywhere between 12 and not really 24, probably 12 and 16 hours. We sedate them. We're going to pass the endoscope, and horses tolerate the procedure really well. Here's me, scoping a horse. He's nice and sedated. I'm just, passing the scope in. He's super quiet. This is my equipment here. The nice thing is there's no guesswork, where everybody's looking at the screen. Here's the screen. You could see my scope coming in. You could see the stomach lining. You can see everything that I'm doing here. And so that's the nice thing about gastroscopy. Again, we get immediate results. We're looking at everything, and the horses tolerate it really well. I do pump air into the stomach to look around, but then we have a suction and we pull air back out. So what are procedural problems? I mean, honestly, the biggest thing would be a bloody nose. Horses have a very vascular structure in their nose called the ethmoid turbinate. And sometimes if they're shaking their head around when you're passing the scope, they can get a bloody nose. That's probably worse for the owner than it is for the horse. They can really, have a big puddle of blood there, and we're sitting there going, no, it's fine, it's all good, they're fine, and they really are fine. But that's probably the worst. But mild gastric discomfort, sometimes when we do have to pump a lot of air into the stomach to get around, if the horse isn't completely fasted, then they can get a little gas bubble. So sometimes we'll give them a little Banamine. And poor preparation. I fasted my horse, but accidentally hung the hay net in the trailer. I bed my horse on straw. Horses are desperate, and you'll see, when you scope them, they will have little bits of shavings, anything they can get their hands on, usually, unless you strip the stall and put a muzzle on, you'll often find things that are in the stomach. But otherwise, there really aren't any procedural problems. Other things is inadequate equipment. So as you can see on the left-hand side, it's very, very difficult to see. So I just say all gastroscopies are not created equal, and you want to make sure, if you have your horse scoped, that it's being done with a proper equipment. This is my view from my scope on the right-hand side, where it has a very bright light source. You can see I can really see everything. I'm not missing anything. I might miss some disease if it looked like the image on the other side. And so it's not really a procedural problem, but it could be a problem with the diagnosis of ulcers. Okay, so now we're going to talk about the different kinds of disease. So squamous disease, you have normal mucosa, they get inflammation, erosion, and ulceration. And here's a view, on the right. Hopefully no one's squeamish, because I do have some pretty interesting and nasty ulcer pictures here. But these are just tiny little ulcers. You could see a little pinpoint here. Here is, again, that margo plicatus. You could see the fluid in the bottom, and here's some ulceration. And how do we grade ulcers? There's been a bunch of different grading scores, but generally speaking, grade 0 is going to be that there's no ulceration. Grade 1 would be single, small, or multiple ulcers, just like I just showed you in the last picture. Grade 2 is a little bit deeper. Grade 3 is, really deep. So people may grade a little bit differently, but we only grade the squamous mucosa. On the glandular, which we'll talk about next, that's more of a descriptive thing. We don't really grade them. So here we are again, we are talking about the squamous mucosa. That's the top part of the stomach here. And so here are just different, showing you different types of ulcers here. These are little linear ulcers, and we can sort of age them to an extent. Like I could tell that these happened fairly recently because there's kind of fresh blood, but not, total fresh blood. Whereas these probably happened a little bit ago because it's starting to heal. And you'll see in some of the pictures where you can, when ulcers heal, it's almost like when you have a cut, it will heal a little bit like a scab. It'll try to wall off a little bit. And so you could almost grade and see about how old the ulcers are. And that can help us because I could go back and say like, all right, this looks like it's maybe a week old. Tell me what happened, a week ago. And sometimes we could figure out, oh, they went to a show. There was a clinic at the barn. They, were in for 3 days because we had pouring nonstop rain. Whatever it happens to be, we can sort of figure out why they might have ulcers. This picture here is sort of from a very interesting case, and this is just depicting that there's all different kinds of things that you can see. And this horse has what we call as desquamation of the squamous mucosa. You could see it's in lines here, and this just shows that this is much more chronic disease. So I know this didn't just happen. This horse has had a problem for a while, and we've got to figure out what's going on there. And location is really important. Where are those ulcers? So again, here, this is right along the margo plicatus here. This is at that lesser curvature of the stomach. See, my scope is coming in. These are sort of right here. This is probably very fresh. You could see it's sort of, more recent blood. This here, these linear erosions here, there was probably something that affected the horse that was, happening right in this location. And I'm going to show you here on this next slide why that location is so important, because sometimes we do see an area like, see, I see these linear erosions here, right here. And what we found is in some of these particular cases, they had a problem in their intestine here, that inflammation, and the food was sitting here, like a food bolus had been sitting here. And so you could see a food bolus, if you could picture that a food bolus was sitting here and causing these ulcers. So we kept getting this, this pattern, and then we're able to get into the duodenum, take a biopsy, diagnose inflammatory bowel disease, treat this, and then we were able to, make some dietary changes and got this to go away. But if I just treated these ulcers and didn't understand why they were occurring, we might not have, we might just be there again and again. But when you see an interesting pattern of where they are and say, well, that doesn't make sense. Why are there just ulcers here? You could probably understand and picture that this is more mechanical. And there was something that was sitting there and causing these erosions. So it's not just, do they have ulcers or don't they? It is, where are the ulcers? How, what is their grade of the ulcers? Again, the location, how old the ulcers are, all those things for us to understand why it's happening. Because, we could treat sort of all day long, but if we don't figure out the why, then, we may just keep going around again. This is a case that I actually rescoped today. The first time I saw this horse here, these are bots, okay? So this horse had a ton of bots in here. So we dewormed him, but this is what he looks like today. And you could see this is after a month of Gastrogard. Those bots cause disease right here along the margo plicatus. It's all healing. And this horse looks much better. You could see there's still a couple of bots there. And, but this caused actually a mechanical problem. So the reason this horse had ulcer disease was because he had this giant lot of bots, and it actually damaged the mucosa to the point that even after a month of treatment, he's still in the process of healing. So again, there's lots of, reasons, but we need to understand the why, so we know how to treat. So what are we going to do with this horse? Deworm him again, but he'll probably just continue to heal at this point, those ulcers there. So what about hyperkeratosis? If you've never heard of hyperkeratosis, this is what it is. It is this yellowing. So again, I talked about when ulcers are healing, they heal like you would if you had a cut and a scab, and that scab looks sort of yellow, and they can heal with that yellowing. But the stomach lining just keeps turning over. So it's making new cells all the time. And that's why after you treat them, it's almost like you can get a brand new stomach, which is really nice. When we get a successful treatment, it's like you start all over again with a brand new stomach. But what we can also tell, again, it's not just about, does my horse have ulcers or don't they? We can learn a lot about their eating behavior, their management, etc. And if you can picture, again, this is the fluid down here. And if you could see, this hyperkeratosis is sort of in this linear type pattern here. And when the stomach contracts, it has these little folds in it, that the folds, if the acid gets up in those folds, you can get this sort of linear, as you can see here, damage to the mucosa. It's back to a little bit about what Al Merritt was talking about with the fluid, the acidic contents damaging the mucosa. And so what I would say about these horses, these are different horses, is, how are they eating? Do they have a good appetite? Are they getting enough hay? Is their stomach staying empty too long? Are they being ridden on an empty stomach? I mean, some of this looks a lot more chronic, but this is important because this is not a healthy stomach, yet these are not ulcers, and these are not, erosions or anything. And in the grading score, they call it a grade 0 for hyperkeratosis. But this is a very important finding because it's not a healthy stomach, and we need to figure out what's going on with the horse and why it looks that way. So again, those are important things. And probably with these horses, it's going to be a lot more about management and how we manage them, how we feed them, what we treat them with before they're being ridden. Are they, again, is there a problem where they're having a gastrointestinal problem and have a poor appetite, or, they don't like their feed, whatever it happens to be. So that's pretty important too. I had to put this slide in because I have been in this situation before where I have, been referred a case because they cannot heal the ulcers. And this right here is a normal variation along this division. You see these little areas here? These are not ulcers. So you will never heal them because they're not ulcers. They are normal variation. So really understanding the anatomy and what you're looking at is very important, because I've had that happen sometimes when people may not understand the anatomy or mistake these for ulcers, because they sure do look like they could be ulcers, but they're not. These are again, a normal variation along that area. Okay, so that is a bit of, squamous disease and understanding squamous disease. Well, what about glandular disease? So when we first would describe ulcers, we kind of just put it into, one big category, and we would just say, it's squamous versus glandular. And we still do talk about it in that way. But what we do understand is that it's very different. And the disease in the squamous mucosa is much more driven by changes, again, in the pH and the acidity and damage to, damage to that squamous mucosa. The glandular disease, which would be this area here, again, the pylorus, the exit of the stomach, and then into the proximal duodenum, into the duodenum here, we don't fully understand what always causes this disease. Sometimes it could be, again, stress and that gooey stuff that I showed you before about the nonsteroidals. Things like stress and other things can also change the character of that and cause damage to this mucosa and cause ulceration. But it doesn't seem to be driven by pH, because this is where that mat of like the low density pH is, and it kind of is used to living in that very low pH environment. So again, what are the primary causes of glandular disease? Again, we talked about nonsteroidal use, stress, and then, bacterial. there's still some questions about whether some of the disease in the glandular mucosa can be bacterial. And sometimes they will have, I'll show you one of the pictures, a look where you could tell that it looks bacterial. And if we take biopsies, I will send them off. And sometimes I do find bacteria and I do treat with antibiotics. So also you can sometimes get, if you have primary glandular disease, you can get secondary squamous disease, because right here is where, again, like the stomach empties. And I explained before where that line of disease was, where the food bolus was. So sometimes even primary glandular disease can cause secondary squamous disease. So here's all different kinds of pictures. Pyloric disease comes in all different shapes and sizes and is way more complicated than the squamous disease as far as understanding what causes it, treating them, how are we going to do this? You could see, again, anywhere from these, again, we don't grade them like a 1 to 3 or 4. We just describe them like, raised, hemorrhagic, bleeding, linear. Here you could see these linear erosions here. This one here, you could see the way the feed material is stuck to the pylorus. That tells me there's not enough of the ooey gooey stuff that would make food slide off. So this is like really, really rough, mucosa there. So these are just different examples. Here's even worse pyloric disease. And one thing I want to tell you is, like, the horse that belongs to this pylorus is actually a very successful show horse and looks like $1 million. You would never know that his pylorus looked like this. And this horse has some, inflammation here, but also this little white stuff. This is where I was talking about the bacterial stuff. When I biopsied this, there was some bacteria in here. So this horse needed to go on antibiotics, but that's pretty horrible looking. And I was really concerned that he wouldn't be able to get food through here, but actually he had no problems with emptying his stomach, and he looked great, but the trainer just felt like something just was off on him, and she was right. And so it could be really, really bad. This horse also had a bacterial infection, and you can almost see where this pylorus looks like flat and squished. And this horse had a gastric emptying problem, and that bolus of food was actually sitting there and squishing his pylorus. And he was skinny. He did not look well, but he looks like $1 million now. He looks great. This horse, again, the whole pylorus just stuck with feed, and this is a fresh, brand new, bleeding ulcer. So these can be, pretty dramatic, as you can see, and sometimes really frustrating. But we don't just look for ulcers when we're scoping a horse. We sometimes find other things. So there is more to it. Like here in this one, you see this? That's a tapeworm. I popped into the duodenum of this horse, and that's pretty shocking to find a tapeworm in the duodenum. But there I'm looking, and here are tapeworms. So that horse needed to be dewormed. And so that's, just a great example of that was not at all what I was expecting. But we learned something there. Bots here, this is actually a cancerous polyp in a horse, pop through this is the pylorus right here. We had to take that off right there. And so that was sort of, great that was found, because if we left it, it could, continue to grow and grow. And here also are some cancerous lesions. It's really uncommon to have cancer in the stomach in a horse. It does happen, but it's really, really uncommon. But it's, just again, that we can learn more than just throwing the scope in to see if they have ulcers or not. We just can learn so much about, about what's going on there. Whoops, sorry to play that disgusting video again. Okay. So why gastroscopy versus treatment? Well, obviously, first, I just explained that you can learn a lot. So it's not just about, if I throw Gastrogard at them, we don't know, like, was it glandular? Was it squamous? Were they grade 1? Were they grade 2? Were they at the lesser curvature? Were they at the greater curvature? Was it only at the pylorus? You really have no idea. And also, there's no way to track progression of disease. So when do we take them off of it? And why, if you're putting them on because it's a behavioral thing or something, it's sort of like, well, are they better? I'm not sure. Are they, how, do I keep going? And we all know that GastriGuard, which is certainly the best product, is quite expensive, and so it's not a sort of cheap endeavor to just treat. But I think also tracking progression of disease is important. This is one horse here, started off like here, this is where we treated, and then here's the resolution. This one here, same thing. And this is, again, where it gets this sort of like scabby type thing here. But we can look and see, okay, yep, they're healing, they're well on their way. These are the things that we're going to do. So we can really learn a lot by looking. Here's some more examples. Here, this horse treated, that's back to that, get a whole brand new stomach. You really can. You can start all over again. And that's the nice thing. And so we sort of want to get them at a point where we can successfully treat them so that we can get to a nice, new, healthy stomach and move on to prevention. So what is treatment? So I'm going to go through the different types of treatment, acid reduction, proton pump inhibitors like GastriGuard, which we're all familiar with, H2 receptor antagonists and antacids, mucosal protection, and diet management. So this is the stomach cell here. And, here's the lumen, so the inside of the stomach. And then this is the barrier that sort of protects, the gastric glands from the lumen, et cetera. And the different drugs work at different points along the way. And so as we explore the drugs, we'll sort of talk about where they work. So antacids, one of my favorite things to talk about, because in an adult horse, you have to use a lot. So people say, well, what if I just give a little Maalox? You would probably have to give 120 mils, 2 big 60 cc syringes, like every 2 hours to have any difference in their stomach. So a very large volume, or tubing them with an entire gallon. Maybe in a foal, we can use Maalox, but really, generally speaking, antacids just don't work in the adult horse because of the need for large volume. Sucralfate. Sucralfate it's basically protects the mucosal barrier. So we're down here in the mucosal barrier, where I personally use sucralfate, and different veterinarians have different feelings about how they use it, is when I have one of those ulcers that's sort of like open and bleeding or deep, where that sucralfate is going to kind of stick to the ulcer and give the horse some relief immediately. So I usually use sucralfate when I have a deeper ulcer and I just want sort of that, again, like sticking to it, more immediate relief. And I don't use it usually that long term. I might be, do 2 to 3 weeks. But again, different people use it for different, periods of time and feel that it has a different effect. That's just my personal way that I do it in my practice. And it is variable depending on the horse and the severity of the ulcers. But some of those that are really deep, the horses feel a lot better immediately with the sucralfate. Misoprostol, this is a really important one for the glandular disease, those pyloric disease ones, because this, it's a prostaglandin analog. So again, remember I talked about the non-steroidals. They block the good prostaglandins, which is hormones that cause that ooey gooey stuff. And so this kind of helps to bring it back, and it increases blood flow and it increases that gastric mucus that just helps to protect the mucosa. And so misoprostol is really good. What are the downsides? It's expensive. And generally speaking, the glandular disease takes a lot longer to heal. The squamous disease generally takes maybe 30 days, whereas the glandular disease can take 2 months, 3 months, even longer sometimes. And I'm not sure that we always need to treat for that entire period of time. I do think that, again, we've learned a lot along the way, and I think that sometimes once we sort of get the mucosa healing, it will continue to heal. But again, the biggest thing is cost. Some horses will get some soft stool or a little bit of cramping, but usually when that happens, we can lower the dose or take them off, and they will do okay. People ask me about oil, and corn oil is kind of controversial. There were different studies. There were studies that showed that it was really good, and there were studies that showed that it was, inflammatory. So I, in general, do not use corn oil because there are conflicting results. And I think there's a little bit more data to show that it does have pro-inflammatory properties. There are different types of oils. And so I think some other oils could be helpful, maybe more for, the soothing effects, but I don't know how much it's going to protect the mucosa. So what about H2 receptor antagonists? What are those? Those are your Zantac or cimetidine, those kinds of things, are ranitidine. And the only problem with ranitidine is, so ranitidine works all the way down here, and it blocks basically the acid from forming, is that you really need to give it 3 times a day. And so it's not the easiest from a compliance standpoint. For a while it was hard to get it, but it does work. It's just that you have to give it more frequently. And so it is an option if you can get it, and that's what your horse is, used to. I have seen some people that only use it twice a day and have had beneficial effects. But again, you really have to give it more frequently. So that's kind of the downside. And then there are the proton pump inhibitors, which basically shut off the proton pump and they stop making acid. So it basically shuts off the pump that makes the acid, so acid is not into the stomach. So Gastrogard is the one that we're all mostly familiar with here. And again, that's what it's doing here. So it's just stopping the proton pump. And when we use Gastrogard, there's sort of different ways to use it. The labeled dose would be an entire tube a day. And I do think back to that measuring the gastric acid, I always measure the acid. So what happens is the horse is natural, again, like 1 to 2, you give them Gastrogard, it might raise it to 6 or 7 or sometimes 8. And, the studies show that even lower doses of Gastrogard can have a profound effect in some horses, actually a lot of horses. So sometimes they don't need a full tube. They may be able to have a half a tube or a quarter of a tube when you're using it more preventative. And so oftentimes when I'm treating a horse, if they don't have a lot of severe disease, I might use a lower dose or measure their pH. If I'm rechecking them, measure their pH after they've had a half a tube or a quarter of a tube to see, is it effective in them? So that can be really helpful for understanding how much your horse needs, because it's, again, it's expensive, but it's a really good drug. And I would rather use that at a lower dose than use other drugs that may not work. Like compounded formulations. The problem with compounded omeprazole, so that's again the drug that's the PPI that's in Gastrogard, is that we don't really know the efficacy. There have been many studies that have looked at all the compounded formulations, and they have very wide variability in how long they keep that pH high to help them, help the stomach to heal. And so you don't know what you're getting each and every time. And you can't just sort of give them, over the counter omeprazole, because the whole way that the product Gastrogard works is it has to do with the carrier and getting it into that horse's acidic stomach environment to work. And I know there's some people that use Nexium, and Nexium is another sort of class of omeprazole, esomeprazole, and it has some really great promise. The problem is that they have to swallow the pill whole. If they chew the Nexium, then it is not effective. So in my hands, I have not seen good effects with Nexium. I don't use it. I know there are some other people that have felt like it's been very helpful and useful, but in the studies, the reason is not the actual drug, the esomeprazole, it's how it gets into the horse and into the horse stomach. So again, they have to swallow it whole, which is generally not going to happen. They're going to chew it. And so for that reason, that's not a drug that I use. Okay, so on to prevention, because that's kind of the most important thing here. We talked a little bit about this, avoid the high concentrate diets, but I'm a very big proponent of, socialization, um, grass pasture as much as you can. But again, the slow feeder, either the slow feeder net or this one happens to be a hay gain one, but there's lots of different kinds of slow feeders. And the thing about it is that, horses come in all varieties of pigginess, and some horses that if you give them some hay, they're going to consume all of it very quickly, and then their stomach, again, instead of being sort of like evenly full throughout the day, it could be like full and then empty and then full and then empty. And the other thing is when you are feeding them in a slow, grazer or a grazing net, it mimics the more natural behavior of them having to pick a small amount and chew and swallow. And again, they're producing more saliva, they're chewing more. It's sort of like, when you're a kid and it was like, slow down, don't eat so fast kind of thing. So those are the things that can be really, really helpful. So I'm a really big proponent of the slow feeders, whatever kind you get. Either it's a net, or there's all different kinds of products out there that are great. And then alfalfa is wonderful. Alfalfa is a really great source of calcium and protein, and it can really buffer the acid. It's actually almost like a natural gastrogard. It will raise the pH in the stomach. And you don't have to give them like, oh, I'm now going to give my horse alfalfa. They could get a very small amount. They could get hay that has alfalfa in it. They can get a quarter of a flake of alfalfa that maybe you give before the grain meal that will buffer that acid that's going to happen naturally after the grain meal. You can give alfalfa cubes soaked that will, again, raise the pH in the stomach so that they're not, constantly having a high pH. I don't think the pellets work as well because I think they really need the roughage for it to be in the stomach long enough. So I'm a really, really big proponent of alfalfa for just helping to prevent. And again, quarter of a flake before a grain meal, maybe an alfalfa snack before you ride. And going along with that, like what I talked about with those mechanical effects is that we want to buffer that acid, and we don't want the horse to have a empty stomach with all that acid that could potentially splash up when we're getting ready to ride them. And so how can we prevent that? Again, giving them an alfalfa snack or something that will, there's a couple products out there that are, labeled for raising the pH. And so you could give them a little bit of those feeds or something like that to just sort of bring the pH up, or have a mat of feed so that when you are riding them, you're not allowing that mucosa to get damaged. And then, of course, reduce stressful situations, that's pretty obvious, but what's stressful for one horse may not be stressful for another. And some of them are performance animals, and you're going to only reduce stress as much as you can. And so we have to have these workarounds and ways that we can manage those horses to limit the, damage to their stomach during their performance career. Also in prevention, conservative treatment with nonsteroidals. We kind of talked about that. I do think it's smart to be conservative, but sometimes we do have to give them, and I'm not afraid to give them. Some people will give them with Gastrogard or UlcerGard. I don't know how necessary that is. Again, if you have a horse that maybe on it longer term, you could give a low dose of the Gastrogard to help protect the stomach. But if you're just giving it to them short term, probably don't need it. And then, again, the Gastrogard and UlcerGard, one of the biggest questions I ever get asked is what's the difference between them? There really is no difference when you're giving a full tube. So a full tube of Gastrogard is the same thing as a full tube of UlcerGard. The only difference is sort of how the demarcations are. So for UlcerGard, it's, marked 1, 2, 3, 4. So you have 4 doses here, but with the Gastrogard, it's done by the pounds. So you can get, basically 5 250-pound doses out of a tube of Gastrogard if you have a 1,000-pound horse, and only 4 out of a tube of UlcerGard, just because of the way that the tube is labeled. But it's the same drug, and works just as well. The only thing that I'm always cautioning about is that we do prefer people to, of course, get Gastrogard through their veterinarian, because we get it straight from the distributor. We know where the product has been. And so you do want to make sure that whenever you get one of these products, that you check the expiration date, because they have a pretty long shelf life. But if you have one that's got is short dated, you just want to be careful that the product is still good. So and then supplements, and again, I am not recommending in particular any supplements, but I'm talking about just a few that I am familiar with that have some data behind them as far as prevention of gastric ulcers. But the main reason I'm bringing up these 3 is because they also carry the colic care program. So that's the main reason. I'm not saying that these are the only supplements for prevention. These are the ones that I'm more familiar with, but even more than that, these companies carry colic care insurance with their prevention. And I think that's a really great thing that they do. If you're going to spend the money on a supplement, then it's nice to have something back for that, and to really have the dedication to follow those programs, because they really stress having good preventative health care throughout the year. So all of these products carry an extra colic care with it. Okay, so in summary, EGUS occurs in all breeds. Clinical signs may vary from none to severe. Diagnosis is made by gastroscopy, and treatment's generally favorable. Prevention is possible with management and drug and supplement therapy, as we talked about. And so I know we're sort of getting close to the 8 o'clock hour, but I wanted to just show a few interesting cases, and then I'll take some questions. This was a really interesting one. This was a 12-year-old warm blood gelding that was at a training barn, and he was training well, but he was kind of a high stress at horse shows, and we were doing this gastroscopy clinic at the time. And so the owner brought him over, and we scoped him, and there's very, very mild disease at the scoping clinic, little grade 1 to 2s. And she said, okay, well, I want to go ahead and treat. So we went ahead and treated him, and then she wanted to have him rechecked, although the disease was so mild that I might have even said, if he's doing well, you don't need to recheck him. But she said, we'd like him to be rechecked. And so we come back and recheck him, and this is what his stomach looked like. Like, we had to go back and look and be like, oh my God, what the heck happened here? Because obviously when we go back here, that's what his stomach looked like. Here, you could see these gigantic ulcers that are trying to wall themselves off here. So we spoke to the owner and said, like, wow, what happened? Well, it turned out that this particular horse was moved from his one stall that he was in. She thought he would like a different stall with a window. And so she moved him to a different stall, and he was out in the paddock with a different horse. And anyway, he was super unhappy and developed these, crazy ulcers during that period of time. And just because we were rescoping him, we sort of found these. So of course we had to treat him kind of aggressively. And when I was talking about the sucralfate, these are the kind that I definitely put on sucralfate, but you could see how the body is really trying to wall these off here. So that was a very, very interesting case. So we gave him Gastrogard, we changed him back to his old stall. We continued with feed and management situations. And then this is what he looked like 2 months later. So here it is on the left here. And here you could see where he just had some scarring, and he'll probably always have some scarring from those, but look how beautiful his stomach healed. So the nice thing is that we are able to heal them, but those things that really surprised me. So sometimes, again, we have to remember what things might be stressful to from one horse to another. This was a little 16-year-old mixed breed pony Louie who they were concerned about possible ulcers. He had been turned out in the field with a new buddy. The buddy was beating him up and he just seemed really stressed and they wanted me to check him out. And when I scoped him, I saw that he had bots and he had ulcers along here. There's some ulcers here. You could just see, kind of had lots of squamous disease. So we dewormed him, we put him on Gastriguard, changed his paddock, and then in 4 weeks I came back and I was very concerned because this does not look like what you just saw, in the last case. I was like, what is happening here? This is not looking very good. And I became concerned that he might have something like squamous cell. And this was a really, really odd presentation. He seemed great. Otherwise, he was happy. He was in work. He's, fit. Certainly his blood work was normal. He didn't look like, he had any issues. So we went ahead and went in. Here I am taking a biopsy. Oh, sorry, you can't see the video. I don't know it. Sorry that the video isn't showing well, but anyway, I went in to take a biopsy. It was actually really difficult to keep slipping off because that area was so hard. It wasn't like normal tissue. And it showed that it was gastritis with neutrophilic, which just means inflammation, and eosinophilic, which is a different kind of inflammation, but keyed me into the fact that it may have had something to do with those bots. And so on further research, I found that you can get some of these lesions, as you saw in the other picture I showed, after bots, but these were really pretty severe. And so instead of continuing treatment with Gastriguard, we actually treated him with ivermectin 4 weeks in a row. And this is what he looked like at recheck. And so that is going away. And so that was a really interesting case because I did not expect that. Usually they just continue to heal. But even here, he's still in the process of healing. But this had a pretty profound effect that was probably still had a parasitic effect in his stomach wall. So again, not really what I was expecting. And here is Stormy, who this was just interesting for me because he came to this new owner with a history of pyloric disease. She just wanted me to take a look since he had a history of pyloric disease, scoped him, his squamous mucosa looked perfect. Pylorus had, some disease. We went ahead, we treated him with misoprostol, gave him a little Gastriguard, and we rechecked in 4 weeks. And this is what it looked like in 4 weeks. And I said, well, he looked great. He was doing great. And I thought, this looks a lot better, but, am I going to keep treating him? So we're having this long conversation. And the owner just said, I actually think that you saw this horse a while ago and had treated him a while back, like 5 years ago. And I went back in my records and yes, I had. And that was a very interesting fact because when I went back, this is what he looked like 5 years ago. And so he did have chronic disease. But I think my whole point of this one is that I think he's fine. I'm not going to keep chasing this because now I know for the last 5 years, and he's been doing great, he's had some of this disease in here. And it wasn't brand new. And it was, sort of change. Like, I think it can change up and down a little bit with, stress and all those kinds of things. But here he is, the same location, exactly the same location. And so we basically stopped treating him and he's doing great. And I think that this is just, it just may be long-term damage. And like I said, we're still learning a lot about them. And this is just my last quick case, 7-year-old thoroughbred mare, behavioral concerns, inconsistent training. She had no GI signs and great management and nutrition. And this is just to show you that she had no squamous disease. Always got to look at the pylorus because the top of her stomach looked beautiful, but she had this pretty severe disease at her pylorus. The concern here is when it goes all the way around, you really want to make sure you treat this type because you don't want it to get scarred in and, get constricted there. And we treated her with some misoprostol and dietary management. And 6 weeks later, this is what she looked like. And she looked great, was doing great. And, this went on to completely heal. So anyway, those were just a few cases. And thank you to the Retired Racehorse Project. This is my retired racehorse. His name is Zach. Now, my son is 18 and going off to college, and my daughter is 20. But this is when they were little, and his name, as I just said, his name was Zach, and I loved him very much. And I got him because he had 2 bows in his front tendons, and he was a wonderful horse for me for 15 years. So very near and dear to the retired racehorses. Here is my information. Feel free to reach out to me anytime with any questions, but I would be happy to take some questions now. And I'm very sorry I went a little bit over, but had a lot to share.
We have a lot of questions. So
Uh,
I'm gonna dive in with the, actually, I have one question of my own. I'm gonna pull rank and ask my own question first. It's really common in especially thoroughbred groups on Facebook when anyone presents with any kind of ulcer-like symptoms, generally the response is like, well, just treat him, just give him, the full month of GastroGuard. Is it possible to overdo that, especially if you're not really sure what you're treating? Like, what happens if you just give GastroGuard for a month?
Yeah, that's a great question. And one of the things that I didn't talk about when I kept talking about changing the pH is that the stomach is acidic for a reason. It's acidic to digest food. And when we change that pH and we change their digestion, we can really change the environment of the stomach. And what I worry about, and I've had a few cases where they've been on chronic GastroGuard for long periods of time. And when we have actually, a couple of interesting cases I had was that even off of GastroGuard, their pH was high and they had ulcers. And so we're looking, their pH is high, they're not on GastroGuard and they have ulcers. Well, we cultured the fluid and they were growing bacteria that do not belong in the stomach. We ended up treating those horses with antibiotics actually to sort of reestablish the flora, brought down the pH back down to normal, and the ulcers went away. And so I think it is not innocuous. I think it is important to treat, and it's important to raise the pH when we need to raise it. So I kind of talked about giving them a little alfalfa before the grain meal, giving them alfalfa before you ride. But we don't want to keep the pH high all the time because, again, it's low to digest food. It's low to keep the bacteria that are naturally in the stomach healthy there and not mess with the microbiome. So I think that we have to be very careful. So I don't think it's good to treat without knowing what you're treating or to constantly treat. The other thing is there's a lot of people, and maybe I'm answering some questions that people have. A lot of people say, well, how do I give GastroGuard before show? Do I give a full tube? Do I give a half tube? Do I give it before? It's one of the most common questions I get. And I think it's okay to give, but if you're showing frequently, what you don't want to keep doing is turning off the proton pumps, turning them back on, off and on, because you can potentially get a rebound effect. And so what you want to do is you want to try to just give them the lowest dose possible, maybe the day before while they're showing, and that's it. But if you knew like for 4 weeks in a row you're going to go away or whatever, it would be much better if you want to treat to have them on like a quarter of a dose the whole time rather than like up and down and up and down. That's not really good for them.
That's interesting. Yeah, because the common thought there is like, oh, just treat 2 days before you leave and the day you show and then the day you come back.
Yeah.
And then do it again next month.
And there may be some horses that need that. I don't think every horse needs that at all. I think that some horses are really just fine, but if they do need that, you just have to be careful that you're not like every week, again, using a proton pump inhibitor on and off and on and off. Even in people, they suggest that you don't do that.
Interesting. All right, I'll get back to the Facebook questions. We have a good question from Katie. Can ulcers happen overnight, or how long do they typically take to form?
Yeah, they typically don't form overnight. Because in some of the ulcer studies, I can't remember off the top of my head how long it took them to be off, feed to develop an ulcer, but they generally don't happen overnight, but they can happen. Like in the study that was done by Marielle, which is now BI that makes GastroGuard. They basically took a bunch of horses at a barn, and they had like, I think it was like 14 horses, and they took 7 of them and took them off the grounds to go to a fake show. And then they were at the fake show for 4 or 5 days, and then they came back. And what they found was the horses that left and went to the show, so in 5 days or so, they developed some degree of ulcer disease. Most of it was pretty mild, but there was even one horse that stayed back that developed ulcers, probably because one of their buddies went, and so in that short period of time they can, but usually not within 24 hours.
Okay, good to know. A question from Callie: is hyperkeratosis applicable to other lesions or tissues, such as yellowing in the collagen areas of the hoof?
It would be different. This is the hyperkeratosis that I'm talking about is specifically of the squamous gastric mucosa.
Okay, good question. This is sort of a general question. How long typically does it take to recover from ulcers? And
yeah,
that there's different degrees, and
Yes, exactly. So the nice thing is the squamous ulcers are usually quite responsive to therapy. So even, some of the really bad ones, like I showed in that case, that it's typically 30 days and you will have an ulcer healed, typically. The glandular ulcers take much longer, can take months. And even as you saw in that particular case, sometimes I think that mucosa gets damaged and it may not fully heal. And so it may always look abnormal and then sort of get inflamed and then not inflamed and inflamed, but so it usually we say 2 to 3 months for the glandular, but the squamous is pretty typical at about 30 days.
Another question from Katie: can omeprazole over the counter be used to treat, and if not, why?
No. So when I was talking about the compounds and the formulation for what you need to use, the reason that GastroGuard is so effective is the carrier and the way that it gets into the stomach and can change the acidity. So if you give just omeprazole over the counter, it will not be activated in the horse stomach. So it does not work. And that's been shown again and again and again. And that's a problem with the esomeprazole, the Nexium, is that, and again, that's in my hands. And I have scoped horses after they've had it, and I've measured pH, and I have not seen a good effect. The drug is good. It's just if you gave them the pills, they can't chew them, and they would have to like swallow it whole, And so there are things. It's not just the drug; it's about the way it gets into the horse stomach. So no, it's not effective.
And I would imagine that, because I've spoken with people that swear it works, and I would imagine that kind of anecdotal evidence is like something else has changed in the horse's life.
And there may be there could be individual differences, and it can be in some horses it is effective, but we definitely know that the compounds are variable, and different people have used different products and felt that they've worked. I've also scoped horses. The reason I say that the nice thing about gastroscopy is it doesn't lie. We're all looking at it. And so you can have a very good idea if you want to know whether your product or your diet is working, or, I could also go in there and be like, perfect management. This stomach is absolutely pristine and great. Do not change anything, which is what I said today to somebody whose horse's stomach was perfect. And I said, whatever you're doing, keep doing it, because it's working for your horse, whoever the horse is out with, however much you're putting them out, whatever hay or grain or whatever they're on. So, you really can learn a lot, and it's probably less expensive than constantly treating them with supplements and drugs.
Right. A couple more questions on Facebook, and then I know we've also got some in the Zoom. Why in the United States can we not give injectable omeprazole over 5 milliliters? I did not know injectable omeprazole was a thing.
I can't answer that question. I don't know.
Okay. One more from Callie. I may be misremembering, but I thought for humans, ranitidine, I promise I was listening. I do not remember how to say that.
Ranitidine, yep, you're right.
Okay. I thought for humans, ranitidine had received some sort of caution on use. I'm assuming she means in humans.
Yeah, I mean, it can again, we can use it in horses, but you do have to give it 3 times a day, and it is sometimes not cost effective. But it is, for any other reason, we haven't really seen any adverse effects for other organs and things like that. I think in people there can be some kidney, renal effects, et cetera, but we have not seen that in horses, if that's what they're alluding to.
Okay. Moving on to the Zoom chat. I have a 1.5-year-old horse with glandular ulcers since last October, treated with Gastrogard for many months. On January 1st, changed to, oh boy, misoprostol and sulcrafate.
Sucralfate. Yeah.
Thank you. Still biting at the sides. We'll meet with the specialist May 11th. Seems to do better on grass. How many hours on grass is too much? I'm afraid of founder. I live in Montana.
Yeah, I mean, glad that you're going to see a specialist. That's number one. That's great. And that's so individual, because that brings you into a whole other category of, horses with endocrine disease and insulin dysregulation, et cetera, for grass, right? And I have had people ask me that question. Hey, I've got my fat horse that can't have hay all the time, and they, what do I do with those horses? And sometimes what we do recommend for them, number one, the slow feeders. Number two, either to soak hay so that you get the sugars out of the hay, sort of feed a lower quality hay so that they have something that they're chewing on and they have the roughage, and those kinds of things is how you can get around it. But that would be a very individual question for that individual horse on how much grass that they can handle. And the specialist could help with that, because we can measure insulin to see if they're having a problem with, again, insulin dysregulation, to understand the safety of pasture time. And that does change per wherever you are in the country. Season, sugars in the grasses are different all over. So it's a bit more complicated.
Gosh, horses are fun. Why are we into them?
Yeah.
They're always a
Keep me
challenge.
working. Yes, they are.
Here's a couple of questions. Do ulcers ever heal on their own without?
That's a great question. The answer is yes. And so you can have these little, back to the person who asked, like, how quickly can you have ulcers? Horses, like, we don't have a scope in them all the time, right? They can get little ulcers and heal, because that mucosa, again, is turning over all the time. And so the grade 1 ulcers, or an occasional ulcer, they will heal on their own. And that's when sometimes, if I am scoping a horse and I can see where there has been some hyperkeratosis, that yellowing, I could tell that there probably were ulcers there that healed on their own. And so then we kind of have to go back to, maybe the why or whatever. But yes, they do have the ability to. Where they get into trouble is chronic disease, other disease, or, an ulcer that's too big for them to effectively heal on their own.
And it's interesting, because I have heard that used as an argument against scoping, of like, well, you might just catch the horse on the day it has ulcers, or the days. But, you're looking at a much bigger picture of, like,
you are, and you learn a lot about stomach health. You learn a lot, like I am saying, it's not just like, yes, you have ulcers, no, you don't. It's, again, like, where are those ulcers? Is this, you can see lots of stuff. Is the stomach perfectly healthy? Is there a lot of, hyperkeratosis? You should always get down within reason. There are times when you can't get to the pylorus if the horse isn't fasted properly, or if the horse has a gastric emptying problem and has too much feed in there, you can't get down there. But it's very important to look at the pylorus. If you just stick it in and just look at the top of the stomach, you could be missing all that disease down there. That last case that I showed you, that horse had a beautiful top of her stomach, but all her disease was at the bottom. You'd miss it if you didn't look. And so it is important, but you can learn just a lot more than just, yes, they have ulcers, no, they don't.
Now I want to just have all of my horses scoped. So thank you for that. A few more questions. Could a 23-day-old foal have an ulcer?
Yes, they can. Ulcer disease in foals is a little bit different. That could be like a whole other talk, but they can sometimes get what's called gastroduodenal ulcer disease, where they can actually have a problem in their duodenum, and that can cause ulcers in their stomach, or they can have ulcers. So usually it's because there's a secondary problem going on. There's another issue in the foal, that another disease process or something else that's going on. But we try to be very judicious in how we treat. We just do not throw. I think we used to throw everything on Gastrogard. It's just not done that way anymore. I don't really treat foals anymore in my practice, but I know some of my colleagues that do treat more of the critical cases, that we just are not so quick to do that anymore, because again, we have to understand that things are the way they are for a reason. And when we change the environment of the gastrointestinal system, we can sometimes create more problems than fix them. And I think we do, I always laugh because I say, look, there's so many products out there, probiotics, prebiotics, all this kind of stuff. If we would just stop messing with their flora, then we wouldn't need to treat them with probiotics and prebiotics. So I'm like very, conservative, and think that the best thing that you can do is good management and feed more than anything.
That's actually an interesting segue, because that's another question that's just coming on Facebook. Do you ever use probiotics to keep the stomach or the acid happy?
It's a great question. I personally don't. There are people that do, and all probiotics are not created equal, and the stomach probiotics are different than colon probiotics. I'm generally using probiotics if I am more for colonic disease and diarrheas and things like that. But for me personally, I don't, but I do know other people that do.
So that's like a case by case sort of.
Yeah, I think it's just your philosophy. Again, like I try not to mess too much with the flora. And so I generally don't use probiotics very much at all.
Is there evidence that aloe helps at all?
Some of the products, like I mentioned, the 3 supplements, only, again, because they have some data and they have the colic care, I think they do have, some of those may have aloe in them, but aloe alone, you just have to remember how big the stomach is and the acid and all that kind of stuff. It takes a lot. So I do not think that probably makes that much of a difference. Do I think it's hurting? No, but I don't know that it's really doing anything.
Mm-hmm. Yeah, I think that's the biggest thing that, I've thought about things like that, but that is just the difference.
You have to remember,
versus what you would put into a horse.
Exactly. It's a lot. Yeah. And they are very different creatures and how they digest and all this kind of stuff. So all the products that are out there, again, that have good data. I mean, I'm a very data-driven person. I think any supplement or anything that you're going to use, make sure that there's an actual physical research paper that is attached to it that shows that its use in horses, because horses are not dogs or cats or people, and they work differently. And just because it works in a person doesn't mean it's going to work in a horse. And so that's my basic takeaway.
Yeah. All right, one question left, and this is a good one. How do you scope a horse that cannot be sedated?
You don't.
All right.
I don't. Anyway, it would depend on why they cannot be sedated. I would not pass a gastro. I mean, first of all, the equipment is very expensive, and you do not want to destroy your equipment, because they don't do it in people not sedated. I wouldn't do it in a horse not sedated, for the comfort of the horse, number one, and also for the equipment. So I personally don't do it.
The person who asked added the horse has heart problems, so I guess cannot be sedated for that reason. So
yeah, I guess it would depend on what that is. I mean, I do a lot of cardiology, and rarely can we not sedate. I'm not saying that you can't in that particular horse, but if you can't sedate them, then gastroscopy is probably not an option. But right. I would really check with whatever specialist is dealing with the heart to make sure there's nothing that you could, because they don't have to be, well, most horses don't have to be heavily sedated. You can, lightly sedative, and it all depends on the scope. Like my scope diameter happens to be very small, and so horses don't mind it too much. And then there's, very individual variation. But I personally would never scope a horse without sedation.
Right. Yeah.
But again, safety of the people. The other problem is you have to be right in front of them because you're going up the nose. So you also want to be careful for yourself.
Yeah. Nobody needs to get punched. So
Yes.
Well, and we've had lots and lots of comments coming in saying thank you very, very much for all this information, that this was super, super helpful. And
Thank you for having me.
If anybody else needs to get in touch with Dr. Polkes, if you're watching this on demand later and you've got a burning question, her contact information is right here on this slide. So feel free to reach out. And otherwise, this recording will live on our Facebook page under the videos tab. And it's also going to go onto our YouTube channel so that you can come back and watch it anytime. So one more time, Dr. Polkes, thank you so much for joining us.
Thank you.
It's been super informative.
Thank you.
All right. Thanks, everyone. Have a good evening.
Bye.